it was the politics, it was the law, it was how you do your transportation, how you do your agriculture. Everything had to do with health. Medicine was just at the very end, when everything broke down, then you needed medicine to get better. But a state of well-being, a state of health, had very little to do with medicine and so on. So, and I was fortunate enough I could take classes at the law school, at the School of Forestry and Environment. I even wanted to take a class at the film school, but somehow the courses clashed and I couldn't. But the possibility was there. And that made the education worthwhile. That made, it was a multi-disciplinary, you know, you just, after the very limited, narrow track education that I had, this was just a, you know, opening up of my mind and my ideas and my thoughts about what health always was. Now, when I was in med school, I happened to read a Time magazine article on these doctors who went all around the world and, you know, did incredible stuff. It was a cover story of Médecins, Frontières. It was, I think, in '85. I think, I forget the exact date, but I saw it, I said, boy, this is what I want to do. And now, how do I get in touch with them? So those days, no internet. So those days, you had, so I used to listen to BBC. So I wrote to BBC World Service. I wrote to them and I said I wanted I want to get in touch with Médecins Sans Frontières. So they sent me the address of MSF, or Doctors Without Borders. We call it MSF. So that I got the address from BBC. They sent it to me. Then I wrote a nice long letter saying I'm a doctor, I'm inspired, and I'm excited, and I want to work with you. So I sent a letter off, and I never heard from them. So that was in '85. So in '95, '93, I had already started my public health degree at Yale, and during the summer, I got a Downs Fellowship to go to South Africa. So I think some of you went to South Africa. So I went to South Africa as well. Yes, South Africa. What was interesting about the summer of '94 in South Africa was that was the summer Mandela became president. So I actually worked with the ANC during the summer, working on, because there were experts coming from all over the world to help ANC prepare itself for their first government. So there were a lot of policies that were being worked on, health policy, education policy. So I worked as an intern on, you know, a group of people who were working on health policy. So it was an incredible, incredible experience. I was based in Durban, University of KwaZulu-Natal, at that time it was University of Natal. It later became University of KwaZulu-Natal. So it was an exciting, exciting summer. And on my way back, I had to transit through Brussels. So I was at the airport and I started talking to the chap next to me, and we were talking, and he happened to be from MSF, and he offered me a job. So that's how it worked. So that's how, and he said, I have this 60 project for you in Ethiopia, and so, but I still had to come back to New Haven and finish my rest of my courses. So I came back, I finished everything, and I finished my master's thesis, and I left in March. I wasn't even here for my graduation. So I left as soon as I could, and April 22, 1995, I reached Ethiopia. So yesterday, 18 years ago. So, yeah, so that's how I started with MSF. And my first mission was to set up a tuberculosis control program in the Somali part of Ethiopia. And it's an interesting place to set up a TB program, because you're talking about a very mobile population. Somalis move around a lot with their camels and with their cattle, etc. And how do you treat tuberculosis in people who don't stay in one place long enough to be, to take the whole course? So these were some of the challenges that we had. And so, but I always thought, you know, I'll do it for a year. It's an adventure. I'll go to Africa for a year, and I can tick it off my, you know, I work with MSF, and then I go on to. I had already applied for PhD programs because I had it in my mind that I wanted to be academic. I wanted to teach, and if I wanted to teach, you know, academic, you know, career, you needed a doctoral degree as well. So I had sort of done that. But what I saw in Ethiopia that year completely changed my life. For me, after what I saw, there was nothing, no other kind of medicine I could practice, but you know, do the kind of work that I was doing in that moment. So that was the moment where somehow I kept coming back to MSF. In the middle of all that, I did finish my PhD as well, but I kept coming back to MSF again and again and again, and 18 years later, I'm still here. So it's just, you know, sometimes, you know, you see things, they affect you in ways that you just don't know how things are going to play out. And I never meant for this to be a career, but it's 18 years, I suppose, is a career. And yeah, so I'm still here. So MSF, today we work in about 70 countries, more than 35,000 people from 100 different countries working together. It's a humanitarian medical organization. So what does it mean to be a humanitarian? And I just want you to just understand this. It's very important. The difference between a humanitarian organization and the difference between a development organization. Humanitarians work to alleviate suffering. Development workers work to alleviate poverty. They're two very different enterprises. Of course, sometimes they meet, but the way you approach it and the way you address it and the solutions you bring to it are very different. They're both very worthwhile endeavors, but they are different. So we are a humanitarian medical organization. Basically what that means is we go to places where people are going through a very, very difficult time. We help them get better. And once they're better, we leave. It's then for them to decide how to live their lives, how to, you know, make decisions about their own security, make decisions about their own communities. We don't tell people how to live their lives. Of course, we give them medical advice. We tell people don't smoke, don't do this, don't do all of that, which doctors do. But in the large scheme of things, we treat patients. We don't treat systems. We're not there to build health. You know, we're not there to repair the broken health system of Congo or the broken health system of South Sudan. We're there to treat people. So. So what are the humanitarian principles? There are 4 principles of humanitarian action. So one is humanity, the deep belief and conviction that individuals, a human being, no matter where they live, no matter what their state in life is, deserve to live a life of dignity, that they should have access to health care. Second, is as a humanitarian organization, we are independent. We are not there to implement political agendas, religious agendas. We don't take money from the US government. We don't take money from the French government. Because today, the reality is that a lot of the aid money that comes are foreign policy tools. You know, they do good things, but development is a foreign policy agenda. Hillary Clinton talked about the 3 Ds, defense, development, and something else, the 3 Ds. So it's part of a strategy, and it is like that for most countries. So we don't take money from this. So you can imagine working in Afghanistan today with American money. You're then seen as part of the American efforts in the country. So we don't take money from, you know, we don't accept money that comes with strings attached. Independent. Second is impartiality. The only consideration for us in providing humanitarian assistance is need. People are, we strive to provide assistance to people who are living in crisis because they're affected by conflict, and somehow they don't have access to healthcare. It could be natural disasters, tsunami, earthquakes, floods, etc. Outbreaks, disease outbreaks, Ebola, cholera, meningitis, and sometimes neglect. Very often in many of the countries where we work, some communities are deliberately excluded from healthcare because they have a different political ideology or they have a different religious affiliation. So usually these are the groups that we work with. So, and we look at their health need, and that's what determines whether we provide assistance or not. So I talked about humanity, I talked about independence, I talked about impartiality, and the last one is neutrality. In conflicts, we don't take sides. We don't take sides with the Americans in Afghanistan. We don't take sides with the Taliban in Afghanistan. We talk to the Taliban, we talk to the Americans, we talk to the Afghans, we talk to everybody, and we say the same thing. We are independent, neutral, impartial. We are here to address only the needs of people. It's very important because that's what gives you access to some of the most remotest and some of the most dangerous parts of the world. Because if they think that you're there for some political reasons, then you can be sure that you'll be targeted or attacked. It doesn't mean that we don't get targeted. We do sometimes, but because sometimes the perception that we are a Western Judeo-Christian organization, even though that's not the case, but people believe it to be true. But as doctors and nurses, we also have the 4 principles of medical ethics that is very important as a doctor when you're standing in front of the patient. These ethical guidelines or moral guidelines help you negotiate tricky situations. So for example, how do you, after a knee giving, you have a woman on an operating theatre, but you cannot start surgery because her husband or her man of the family has not given permission. And he's nowhere to be found. Do you operate? Do you not operate? Because if you operate, our teams can be in danger. Because next day they'll come with sticks and knives and kind of demand to know why she was operated on without permission. These are the kind of cultural issues, and we don't say whether it's right or wrong, but you have to negotiate this in order to be able to provide service. In Sudan, we had a doctor, an Italian doctor, who refused to treat a patient and left the MSF mission because he said, I cannot treat this patient. Because we knew that this person was a rebel soldier who, if and when he got better, he would go back and kill more people and rape more women. And he said no. So these are the kind of, as doctors, you are faced with sometimes these sort of dilemmas, and you have to decide how you. So you have medical ethics to guide you. The 4 principles are autonomy, that patients make decisions. So you have to give them enough information for them to make the right decision. Beneficence, that whatever you do is actually going to benefit the patient. Non-maleficence, sometimes that whatever you do no harm. And the last is justice, the principle of equity that comes into play. So these are basically some of our guiding principles, and there are also operating practical principles like effectiveness. It's all well and good to get onto a plane and go to Africa and to provide, but it has to be effective. It's not just opening a box and handing out aspirin. It has to actually, patients have to get better. And that's, I think, one thing I'm really proud of in MSF is that we have had a big role to play in the increase in the quality, or the improvements in the quality of care over the last 40 years. 40 years ago, even us, we get onto a plane, box of food, box of medicines, we give it out, and you're humanitarians. But today we understand that if you really want to treat people with respect and give them dignity, then you also have to provide them with the best care possible. That's how you respect them. That you don't make a distinction between the kind of care you provide to your patients in Providence and the kind of care you provide to patients in Sudan. So, yeah, that's what we do. I don't know what else to say. If you have any questions, then it'll help me guide. It'll guide me a bit better in what I need to talk about. Yes. You will give me $1 billion.
Oh no. What would you do in that case that you just were talking about with the woman with no man? What would you do?
Well, in the end, ultimately, you have to ethically, you have to look at the patient in front of you and do what is best for that patient. You don't do what is best for the family. You don't do what is best for the, and that's you know if you look at human rights, we are not a human rights organization, but it's if you look at human rights, if you look at the very Western perspective, it's very individualistic compared to the very, if you go to Japan, etc., they're much more oriented towards family, community, etc. Well, here we look at it in a much more individualistic way. But when a patient is in front of you, the objective is to save that patient and not to worry about culturally. But then you'll have to deal with the consequences as well.
So speaking to that, what's been the most difficult cultural challenge that you've had to face?
Vaccination campaigns, for example. Today it's so political. Working in Nigeria, working in other places, I think there's always conspiracy theories. In Nigeria, I remember people telling me that vaccinations are all about sterilizing people and reducing the number of Muslims, reducing the number of Africans in the world. But all of this, what the American government did in Pakistan doesn't help. By using a vaccination team to identify Osama Laden's location has actually made the situation worse for, I think since then, 15 polio vaccination workers have been killed in Pakistan and in Nigeria because they are now being suspected of being spies. It just gives credence to all sorts of crackpot theories that are going around. So it is, there are real challenges, there are real security issues associated with delivering care in some of the remotest parts of the world.
Can you speak more about delivering care to women specifically? Different parts of the world is something I'm very interested in.
Yes. So we consider, especially in refugee situations, but not only in refugee situations, women are some of the most, women, children, and also women-headed households. They are particularly vulnerable to, to being preyed upon, but also to disease, poverty, etc. So in all of the places where we work, we make a conscious effort to put women in the center of our programming. So to give you one example, in refugee situations, people come in large numbers, they form these big camps, and then women go out to find firewood, etc., and then they bring it back, and they make meat, they cook food, etc. But it was discovered that the more women traveled away from camps to collect firewood, the more likely they were to be raped. So then, it sort of, we turned it around, we started providing firewood so women didn't have to travel. And we also realized that food distribution, usually food distribution works, you first go to the community, you talk to the elders, you tell them this is how much food you have, and then you give it to them to distribute the food. But then you expect them to be just, but that's not always the case. And it's also a very male-dominated, very often male-dominated societies. So changed it around again. I'm not saying it's just MSF, but the humanitarian community started distributing food to women. But then this also completely changes the dynamic of male-female relationships in society as well. It kind of completely turns it upside down. So I think that's not necessarily a bad thing, but you find a lot of men can't deal with it. There's a lot of domestic violence as a result, a lot of alcoholism. Men who were someone in their society suddenly become important. They're important because they control food and they control resources. If they're no longer in charge of that, then, maternal mortality, huge issue. Women don't have access to, women shouldn't have to die giving birth. I mean, it's, it's what, it's the most natural thing in the world in some sense, but the sad reality is many of the countries, women die giving birth because they do not have access to delivery services, do not have access to emergency obstetric care. So these are things that we're working on as well. Do you have a question? Did you?
So am I going back to before when you were talking about the dangerous situations that these healthcare workers or doctors are in? I'm just wondering, like, at what point does the safety and security of, say, doctors working with MSF kind of outweigh the danger of the situation with the deaths?
So we take security very seriously because in the end, if we can't keep your team safe, then you're not going to provide any kind of care. So that's important. But we're also a risk-taking organization because if you don't take risks, you're not going to reach the people most in need. So, but we take calculated risks. We do a lot of research. We talk to a lot of people. We do endless rounds of analyses before we decide to send people to certain places because safety is important. Having said that, some of our people have been affected. Today is 559 days since 2 of our colleagues from Spain have been kidnapped. They're still abducted. They're still not free. We have 2 people who died in Somalia in 2011 October. So these things do happen, but they happen very rarely. That's not an everyday occurrence. I remember in 1993, 94, we could actually get people to stop fighting to carry out vaccination campaigns. So you go, you negotiate, you wave a white flag, we tell them that we need to vaccinate children, they would stop fighting for a day, and then you vaccinate and then they start fighting again. Which is not unlike, World War II, World War I, there were times when they would stop fighting, but these days I think it's becoming less and less impossible to do things like that. Times have changed. You had this.
I know that you said you try to keep away from policy making as much as possible and try to just treat patients, but to what extent do you exchange information and techniques with local doctors when you're working in there?
A lot. I mean, let me qualify what I said. So we treat patients, we don't treat systems. But you have to interact with systems to be able to treat patients. But we are not there to treat them. Because what happens, very often what I've seen is, when people are focused on building health systems, etc., it's all about the system. And then it's all about how patients can fit into that system. Not the other way around, how the system can be designed for the patient. Very often, it's a very elementary thing, but it's something that always gets lost when people start building health systems. Policy, so one of the questions I get asked a lot, so you've been working in Sudan for so many years, you do all of this, what's sustainability? I mean, any of what you do, but after you leave, nothing remains, what's the point, etc. But I can tell you that a lot of what we have done have become sustainable. So for example, the way we treated nutrition, HIV/AIDS, malaria, sleeping sickness, Kala-Azar, etc., have become international policies. It's now the internationally accepted way of providing care for the people affected by these conditions. So, in my notion, sustainability is not about my little project in Ethiopia going on for 20 years, 30 years, etc., or training a few people in Ethiopia. And that sustainability of ideas, that you build a model of care that can be taken up by anybody. It could be another organization, it could be the government. It could be taken up, replicated, scaled up. That's sustainable. It doesn't mean that we have to do it ourselves. Because after all, we are a small international organization. We are not the Global Ministry of Health. So our objective is never to provide or guarantee health care for people in all of the countries where we work. Our objective is to be a catalyst for change. That means when we work, we engage, and when we engage, quality is important. We are very, we do a lot of operational research, we publish a lot, and so the lessons we've learned, it's very important for us that the lessons we learn are transmitted both in the country and outside the country, so other organizations can also benefit from it. So that's what I mean by being a catalyst for change. So you develop models of care so that they can be then taken on, improved upon, replicated, scaled up. That's where sustainability comes from. Not by building a hospital in Ethiopia and then hoping that the Ethiopian Ministry of Health will take it over and that they will provide some. That's the small s sustainability. You have to think of the big S sustainability.
So which public health threats do you think should take precedence in being that catalyst for change right now?
Which
public health threats would you say should take the most precedence currently in being a catalyst for change or in the upcoming months and years ahead?
Well, I mean, we have some stated priorities for the next years. MDR-TB is something that we're working on, but there are many, vaccines, for example. After years of, you've probably heard of EPI programs, right? The expanded program of immunization, where people get, governments and UNICEF guarantees free. It's now, it's now getting very expensive to provide vaccines. The new vaccines that are being, it costs $21 a shot, and there's so much work to be done to get pharmaceutical companies to stop thinking about profit. I mean, they can still make the cost of vaccine. I heard somewhere the actual cost of production is $3.60, but they're charging $21. So I mean, we need to when you have. We know after all this time, we know that a market-oriented pharmaceutical companies don't meet the health needs of the poor people. We have neglected diseases like sleeping sickness, Kala-Azar, Chagas disease, which have had no new drugs come in, I don't know, in the last 40, 50, 60 years, because the people who suffer from these diseases are poor, and even if there was a new drug, they can't pay for it. So companies don't do research and development. Same with vaccines. The people who really need the vaccines are not going to pay for it. So there has to be a different way of doing research and development. And a lot of the research and development are done in universities. But the universities also want to make money. So they sell their research to pharmaceutical companies and they get royalties. So I think most of the researchers in the university do research for the right reasons. They are there because of their interest in science. They want to see good being done. But of course, university administrators have different ideas. And so these are things that students in universities can engage on, and there's a really interesting group called the Universities Allied for Essential Medicines, and they are doing exactly this. Students from Yale, from Stanford, from British Columbia, from Denmark, from Brazil, they're all coming together to push their universities to do responsible research and development, and do research and development on issues that affect real people, and it's not all about antidepressants and all about erectile dysfunction.
How many languages do you speak?
I don't speak many languages. I'm not very good.
How do you communicate with your patients?
Very often there are, through translators, intermediaries. Sometimes you just have to touch them. I think, so maybe I do have bedside manners after all. No, but it's how you want to communicate. I think sometimes, most of the times what people need is to feel like they can get care. And care is much more than, giving aspirins and then sending them out. It's all about how you talk to them, how you treat them. Most of the care, so we have 35,000 people working all around the world. Only 10% of them, about 3,500 people, come from outside the countries. The others are from inside the country. So we hire a lot of doctors, nurses, etc. from inside the countries where we work. And so we provide care through them. And a lot of the work that expatriate doctors and nurses do is to coaching them, guiding them. And of course, in extreme emergencies, they actually provide the care themselves as well. As we did in Haiti, as we did in Pakistan, as we do in many other places. So that goes to the question that was asked earlier about how we transmit information to local doctors, etc. Because we work very closely. There's a large degree of mentorship and coaching that goes on.
What are some of the important news articles, publications, and magazines that you read to stay current in global and domestic health?
So one of my required reading, when I studied public health, one of my required readings for my Global Health Club, Introduction to International Health Class for New York Times. But of course, there are many newspapers, and you get, I read on a regular basis. I can tell you that I read BBC, I read New York Times, I read The Guardian in the UK, I read The Lancet, very important. And, well, I read The New Yorker, which has not much to do with the global health, but they do actually have very interesting articles. But this is, one has very little time to read. Personally, I don't have much time to read. But these are the sources that I go to regularly on the top of my reading list. But today more than I think any other time in history, you have to triangulate your news. You have to read the story from different perspectives. You can see from my choices, they're all left of center, left leaning, but you have to triangulate your news to get a sense of exactly what the issue is. So New York Times, of course, it has perspective. I read it because I align myself with that kind of, but it's probably equally important to watch Fox News to understand what the other side thinks as well. Because if you don't understand the other side, then you don't have a way to negotiate, you don't have a way to understand. This is very US specific, but in every country you have these opposites, and you have to try to make that attempt to understand different points of view to be able to do the right thing, I think, personally.
What's an underpublicized or underrepresented campaign that MSF is working on that you wish more people knew about?
Today, I think not many people know what's going on in Central African Republic. I think not many people know, and this vaccine issue that I think if you look at what's going on in global health, there are these, I don't know how many people know about Gavi Alliance, which is the global vaccine alliance, where they're trying to make vaccines available for people. So there's a lot of work going on, but if you go into detail details, you're realizing that some of the trends are going in the wrong direction. So it's a lot of underwriting of pharmaceutical companies, but not really efforts to make vaccines affordable. So I think people rather pay a lot of money to provide subsidies to big pharmaceutical companies than to really try and make research and development and to bring out affordable vaccines. So we've been working on many. The other campaign that we're just getting started on is what we call the Healthcare Under Fire campaign. Really to bring to the public's attention that today doctors and nurses are being targeted just for being doctors and nurses. This happened in Bahrain, it's happening in Syria at the moment, it's happening in Myanmar, it's happening in so many countries around the world. And this is a real problem. I think even in the US today, medical workers, especially in emergency rooms, medical workers are 6 times more at risk of being personally attacked than other service providers. So these are issues that we're concerned about and we're trying to consistently raise.
What would make, like, or prompt those type of individuals to be attacked?
What would
prompt, like, the doctors and nurses to be at a higher risk of attack?
Yeah.
Just that, like, if someone...
Rage. I mean, I think in the US and in Europe it's rage. But part of it is also how we communicate. I think very often people don't have a full understanding of what they're going through, what their options are. Medicine used to be a very paternalistic. It still is in many ways. The doctor knows best. The doctor will tell you what to do, and you basically take it. And sometimes when you're ill and when you're very sick, you also want someone to take charge and tell you what to do, right? But it's very important that the medical profession also recognize the autonomy of patients and give them enough information for them to make decisions. But you can imagine in some of the clinics where we work, we have 200, 300 patients a day, and we have perhaps 5 or 6 doctors and nurses who see this many patients. We're spending sometimes a minute and a half. How much information can you transmit to me? I'll tell you a story about, I went to respond to an Ebola epidemic in Congo in 2002. 2002, there was an Ebola outbreak in the pygmy population in Congo-Brazzaville, which is bordering Gabon. So we heard about the, so almost always, just before an Ebola outbreak, you have what's called a die-off. So you have, in forests, you have what's called ape die-off. You find a lot of monkeys, dead apes, etc. And they're dying of mysterious reasons. So you know something is going on. And very often, in the pygmy population and in places in that area, people eat monkey meat. So it's just a matter of time before the virus skips from animals to human beings. So we went, and it's scary. Scary for the people who are going through it, scary for also people like us, because it's an extremely contagious virus, and if you get it, I mean, mortality rates are very high. So we are dressed like spacemen, literally, completely, completely protected, and we walk around the village like that. And we take sick people, we take them to isolation ward, and very often, 80%, 90% of the time, what comes out is a dead body. So if you are a pygmy, what do you think? These foreigners coming, they take your family member, they take them to isolation ward, and then they give a dead body back. And how do you start explaining germ theory to people whose idea of life and disease is all about ancestral, spirits, etc. So there's so many different levels of people just don't understand. So of course they're afraid. Of course they act out. Of course they get dangerous. And we also don't, very often coming from different cultures and we don't know how to communicate. So to carry on with this story, how you control Ebola outbreak is you do it by breaking chains of transmission. So you have to stop people spreading Ebola from one person to another. You have to break that chain of transmission, and then you contain the outbreak. And a patient is most contagious when they've just died. And the pygmy burial practices involve cleaning the body before they bury it. So they clean the body when it's most effective, and of course they all get it. So we tried really hard to convince people not to clean the bodies, but they don't do it because it's, ancestors will get upset and, all of that. We managed to convince, in that outbreak, we managed to convince one family to do that. So we provided transparent body bags so they can see the body, etc. We tried different ways, and so they can, clean the body bag rather than the body itself. And so one body, and we were very happy. We left, and they dug the body out, they washed it, and then so that's how strong these beliefs are. And then we learned our lesson. After that outbreak was over, we sent in an anthropologist to understand a little bit more about how they think about disease, how they think about, and they had legitimate beliefs as well. They say, okay, well, our children are dying of measles every day. You come now because you're afraid that this is going to affect other people. You don't want this to spread, so you're more concerned about outsiders than about us. What about the children who are dying every day? These are questions as well. 1 year later, there was another outbreak in the same area. And this time we had were able to manage it a bit better because we understood a little bit more. And what we did was, the year before, the isolation ward was, a brick building, high walls, so you have no idea what goes inside once you take the body. So what we did is we managed to make the perimeter wall transparent, like the plastic sheets, so people can't come in. So entry is restricted, but people could see inside. And then we started giving patients phones so that they could stand and they could talk to their family members. So they knew, they could tell them about how they were being treated inside, that they were being given food, etc., etc. So we took different measures to kind of bring down the tensions in the community. So, there are so many layers of misunderstanding. There are so many, and sometimes, it's just our arrogance, and we just don't take the time sometimes.
With such a big organization and so many countries and so many people, how do you keep everyone on the same page? Like, how do you organize such a large movement across the world?
Very good. It's not always easy because 35,000 people, we all have different ideas about what it means to be a humanitarian, and they're all right. But as an organization, you have to find a way to work and to move forward. So I think, in spite of all of the differences, I think in the end, I think people are reasonably clear about what we do and why we do it, and that sort of keeps it together. But different people have, so for example, this patient needs to be put on a plane and flown to the capital for surgery, and we need to do it right now. But if that comes at a cost of attending to several other patients, so people also have very individual preferences and ideas. None of them are wrong, but it has to fit into an organizational way of doing things, because there's some amount of triage involved on what lives can be saved and what lives can't be. You have to look at resources, what resources we have and how best to employ them. So these are all huge considerations. But important is to have a clear set of principles by which you operate. So I told you about the 4 principles of humanitarian action, the 4 medical ethics. And this is, so even when we stray from that, the everyday practice of delivering humanitarian assistance is finding that right balance between being principled and being pragmatic. There are always compromises to be made. But it's important to have those principles because you stray from it, but you know exactly where to come back. You know where home is. And that's important. But because if you don't have those principles, you stray, and then that becomes the new norm, and then you stray further, and before you know, you don't recognize yourself anymore. So the principles are important. I'll take someone two of you, and then I'll come back to you.
What goes into MSF's decisions to start working in a particular area, either a new area or a new project?
Like I said, need, and and how disadvantaged the populations are.
And conversely, what goes into the decision out to everybody?
When we feel that we've sort of met the objectives for which we went to a country and that there is someone we can hand over to. We never try to duplicate services. Our objective is to hand over services to someone who can take it over. And we try to focus as much as possible on hard to reach patients and hard to treat patients. So for example, in Myanmar today, we have 30,000 patients on HIV treatment. So many of them are first-line, uncomplicated patients, and we would like to hand them over to the Ministry of Health so that we can focus on complicated first-line patients and second-line patients, much more difficult to treat. They require much higher level of care as well. So we know that the government systems don't have the capacity to take this. So that's how we make decisions. Like I just came back from Ethiopia, where we've been there since 1978. But during this time, 30 years, 35 years, we've done 150 different projects. So we're constantly moving within the country as well to going out to places where there is a famine, or there is a disease outbreak, or a refugee influx. So even within the country, we move around. You had a question?
Yeah, my question kind of goes back to the cultural challenges you face. I know you talked about understanding the cultural differences sometimes is a realistic solution, but what other solutions have you found like that works for treatment when there's such a cultural gap?
To talk, you have to communicate. There's no way around.
Yeah.
Sometimes we partner with local organizations who have a better understanding of their own community, and it helps us they sort of mediate between us and the patient. See, we are not a grant-providing organization. We believe in direct medical action. Our doctors and nurses are in front of the patients. They're the ones who are. So that's important for us. But in order to provide what we call direct medical action, it's important to take some time and effort understanding. Medicine is in some ways easy, especially physical medicine, vaccine, antibiotics, everything. But imagine mental health. It's much more difficult to negotiate that. Because even in our own societies, there are so many different approaches to mental health. And you can imagine that this confusion, then compounded by language, culture, etc., becomes very difficult to determine what is the best approach to address mental health issues in many of the countries where we work. So we're still learning. We're still kind of, but we try not to take on a relativist approach. So we try not to. People are people, and there are certain physiological and biological responses to trauma or disease that no matter where you are, you go through that. But then there are certain behaviors and certain mental health, for example, again, it's important to see them as people and then provide the best service and not bring culture too much into it. You need to know the culture. You need to know how they understand illness. You know how they understand or seek healthcare. These are very important. But we are by and large operating with a very Western allopathic medicine, medical approach. So we're not doing Ayurveda, Chinese medicine, or homeopathy. Because a lot of people ask about different medical philosophies, how we apply it. We don't. So we've also made a choice that we're going to use Western allopathic medicine as a way to address medical issues in the place of it.
One more question. One more.
One and the last
Bridget?
question. Yeah.
Oh, anyone?
Would you say that most of the issues that MSF addresses are related to infectious disease, or mostly linked to a problem with infectious disease?
Yeah. So by and large, I think, so maybe it's, I think by and large in the last 40 years, we've been dealing with infectious diseases because that's, you know, we're talking about saving lives, child survival, maternal mortality, large pandemics, epidemics, etc. Malaria, HIV, TB, you know, cholera, meningitis, parasitic diseases, etc. But now there are several transitions that are going on in today's world. Epidemiological transition. People are living longer. So even in the countries poor countries where we work, children are living, you know, living up to the age of 5 more and more, and adults are living longer. So you find a combination of infectious disease and non-infectious disease, you know, non-communicable disease, communicable and non-communicable disease. So you find, okay, how do we in the middle of Sudan manage hypertension? How do we manage diabetes? And so we have to find new models of care for that. So people are living longer, and people, as a result, suffering from new sets of illnesses. That's one epidemiological transition. Second is environmental transition. I mean, the climate is changing. Last year, for example, for the first time, we had a malaria treatment program in Greece. You know, the people are moving, climate's changing, so you know the malaria is moving further up, further north. You know, so you will be faced with a lot of that, I'm sure, in the future as well. And also related to climate, you probably would have noticed the natural disasters are getting much more frequent and much more severe. So we have to be prepared for that. Even in Japan, which is probably the most prepared country for natural disasters, they couldn't cope with tsunami. I mean, they couldn't immediately cope with the tsunami, the earthquake, and the nuclear meltdown. Even there, we were able to provide help for the first few weeks, 3 weeks or so, and then they sort of regrouped. So even the best prepared countries have problems dealing with it. Then urbanization. Today, for the first time in history, we are an urban society. More people live in urban areas than not. And that has its own problems. A lot of people come to urban areas looking for work, looking for a better standard of living, but instead they're caught in a downward spiral of you know, disease, poverty, violence, and that brings a set of, you know, there are people living in crisis, really. It's not war or conflict, but it's their existence that's in crisis. So these transitions are happening, and for an organization such as, in the end, we have to be able to provide the care that people need to survive. So maybe it was cholera, and you know, mostly cholera in the last 40 years, but then maybe in the future it will be mostly diabetes. Who knows? But also, you know, the public health consequences of violence, you know, social issues. We need to address antibiotic resistance is a big, huge problem that we haven't even begun to scratch the surface. Yeah, we fully realize that there are a whole new set of issues that we need to start dealing with and develop norms of care for. Ask question because you have to ask.
So you talked about the necessity of making very difficult decisions, and do you think that that coupled with having to keep this balance between being pragmatic and principled contributes to burnout? And also, how does someone like you who's been working with MSF for 18 years avoid burnout?
How do I do what?
Avoid burnout, like
Yeah.
people.
Yeah. So burnout is, I think, a reality of in the kind of work we do. I have lots of friends who burnt out. You have to, and I think I was discussing with you guys, right? I think you have to maintain a certain perspective. I have a lot of friends who worked in Ethiopia, Congo, Sudan. They come back and they're totally off. They say, man, that's the real life, and what are we doing? Look at those people suffering, and our life is not real. Well, their life is real, your life is also real. There are different realities, and we have to just learn to deal with it. And if you're not able to negotiate between, and not feel guilty about spending, $60 or $100 having a nice meal outside. Of course, it can buy, so many vaccines for kids, but you have to balance your reality with their reality. And but the important thing is not to be paralyzed by it. The important thing is to recognize that there are different realities and find ways of mediating, find ways of still contributing or still making a difference. So try being part of the solution then, rather than being part of the problem. And live responsibly and live ethically. That's all I have to say. I mean, that's how I've been able to, and I've also taken breaks for periods of time in between to just do other things, just completely different, use different parts of my brain for a period of time. And then you need that. You can't do this non-stop for 18, 20 years and not be affected.
I had one last question. What can this group and myself do to support your mission with MSF? What can we do? How can we help you?
I think there are many ways of engaging, and some of you will perhaps join MSF in the future as doctors, as nurses, but not only. Maybe engineers, journalists, lawyers. Our team is multidisciplinary because you need all of them to be able to do the job. So some of you will get onto that plane and go to Africa and other parts of the world. But for those who stay here, I think it is really important to engage with policies. I am firmly convinced that today the decisions that are made in Washington and Brussels have a huge impact on the lives of people. Every time the Republicans come to power and they say that the US money cannot be used for abortion care, it has huge implications on the lives of people. So it's a simple thing. You think, oh, it's a matter of principle. Yeah, okay, fine. But it has huge implications on the lives of men and women in the countries where we work. How we formulate our trade policies. Pharmaceutical companies, huge lobby. I mean, if we think the pharmaceutical companies are the bad guys, wait till the food companies. I mean, today and in the future, you will find you'll be working in countries with two types of malnutrition. The skinny kids and the obese kids. And it's all about salt, sugar, and tobacco. And so we want to take on food companies. What I mean is that you need to engage. You need to know what your government is up to, what policies are being made, how the environment, emissions, and all of these I think are very important. And the US being what it is and its position in the world today, you have to engage. You have to harangue your senators and your congressmen and ensure that they're responsible for the way they make policies. Absolutely important. So that's how you can engage, and also while you're students, also make sure that in your environment that your universities are also acting responsibly, making sure that any research and development that is being done here it can benefit the world at large and not benefit some company in making profit. So there are so many layers of engagement, so many levels at which you can engage, and they are all valuable. They're all equally valuable.
Thank you very much. Please don't forget tonight, his presentation is 7 o'clock in Providence. And thank you once again. Absolutely superb. Thank you for your visit to Kingston.